So it's not often that a meeting, a workshop runs so well that we're actually ahead of schedule, but we are. So thank you, and sorry to those of you who are wandering for another 15 minutes while we wait to reconvene, because we're reconvening now because we recognize this has been a long day. We want to hopefully amuse you, hopefully, have more discussion, but then give you a breather because we're going to come back in the morning and do this all over again. So I'm David Chambers. I'm here at the NCI, Deputy Director for Implementation Science. I get to introduce myself first, so I'm going to give you a little bit of an intro around implementation science. This session, as you can see, is around healthcare delivery approaches to development, implementation, and evaluation. It should have a part 1 at the end of it, because tomorrow morning we're going to get into even more of this. But to whet your appetite, we're going to have a few talks, a few discussants. So I'll kick things off, turn things over to Juan again, who deserves gold stars for being willing to address and play multiple roles here from the CDC, and then Joy Larson-Hadel, who is the past president of the National Society of Genetic Counselors, focusing on workforce, on capacity, and her experience in thinking about how do we actually scale up different services. And then we'll have two discussants, Muin Khoury, who many folks know is the founding director of CDC's Office of Public Health Genomics, and then David Ransohoff from UNC, who all of whom have wonderful bios that I'm not going to take as much time to read, but we're grateful for their comments in advance, and then grateful for the audience discussion that will follow. So there's that. Okay, so what I wanted to do, and it's been really helpful listening to such tremendous expertise over the day so far, is in effect say a lot of the things that you've been talking about already, but put a slightly different spin on it, because I think many of the implementation challenges that have come pretty much in every single talk are the things that we focus on the scientific end as we're trying to develop and then deliver the knowledge base around implementation. And so hopefully you'll take this ride with me as mood lighting prevails, then hopefully we can think together about what are the ways in which some of these decisions that are often confronting us in real time are things that we can plan for, things that we can learn from, and ways that we can build the knowledge base toward better optimization of what we know to be high-quality care. So what I'm briefly going to go through is just a couple thoughts about implementation science overall, at least some thoughts about how it might relate to what we're talking about today, give you a bit of a sense of some of the activities and resources that we're in the midst of in the implementation science world, push a little bit around a couple of the assumptions that I think too often limit our thinking about how to make progress in terms of the value of biomedical research, and then end with some discussion questions that other folks will take on as well. So just by show of hands, this is the audience participation portion of this. How many have seen this slide? Okay, a few, but not many. What this slide is showing, this pulls together actually 17 years ago, and this will key time point, as you'll see in a moment, a study that was saying, let's assume that the end product of our research is the publication, is that wonderful high-impact publication. What happens if our goal is to try and see the findings implemented within practice? On the left side, what you see are all of the ways in which we're losing that valuable information. Maybe there's negative results that made it hard to get published. Maybe it never makes its way into databases, into reviews, into guidelines, into textbooks, and maybe it doesn't get its way toward implementation. On the right side, it basically just tried to talk about, on average, how long does this take? The reason why this slide is important is because it walks through the rationale behind a factoid that often gets mentioned without consideration of where it came from. Here's the factoid. And I'm guessing that more of you have seen this mentioned many times as we talk about the challenge of getting our research into practice, that it takes 17 years to turn 14% of original research to the benefit of patient care. This is the reason why many of us and many of you in the room are turning your attention more to these challenges of how do we take these findings, how do we take these effective tests, these effective diagnostic procedures, these effective treatments and preventive strategies, and turn them into standard care. This is the reason why we can't just assume that the end point of our science is the publication. And this is one good reason why we have this kind of challenge, because we're often at this, with this mentality, and I'm guessing you can fill in the rest of the sentence, 1989, Field of Dreams, the voice above Kevin Costner's head saying, if you build it, they will come, right? But they don't in many cases, right? They do not come. You can see this lovely baseball diamond right here. Okay, it's February, so maybe that's one reason, although spring training is starting. But there are many, many reasons why people don't take the interventions, the innovations that we create. Maybe it's a place where baseball is not all that common. Maybe it's just other preferences. We really need to think beyond the science push, which we've been very good at to a point. But implementation science is really trying to make sure that we don't end with things on shelves, that we don't end with these wonderful innovations that nobody actually is able to use. So when we think about genetic testing, and here's just a way in which sometimes these wonderful tests break down if we fail to think about different stages related to implementation. So even if genetic testing gave us the ability to identify optimal treatment for a specific illness, reduce risk for health populations, as we start to look at what happens as that tries to make its way to become standard care, let's assume of all those who are insured and all those insurance companies, say the scenario is that half of them are choosing to provide this genetic testing, choosing to reimburse for it. Let's assume that of the systems that are working with those insurers, they're only the half of the systems in the world. By the way, this is actually an optimistic look, so I'm sorry to say that sometimes the actual is even less than this. But let's say half of the health systems are willing to go that next step and think about how do we train clinicians to prescribe testing, how do we train folks to be aware and trying to identify when testing would be indicated. Now, let's say they go that next step, right, and those clinicians are trained, but say only half of those clinicians, because we know that continuing medical education and other continuing education has its flaws. Let's say only half of those clinicians go that next step and say, we're now going to take this training and we're going to apply it, we're going to start delivering this tests. And let's say, you know, again, busy group, we only get to half of those patients within, you know, who could potentially benefit, who are seen by those clinicians to get the tests. What it basically shows, and even in the scenario where you have perfect access, perfect testing, perfect follow-up, no problems in the system, just as you see going through those steps, we're down to just 6% of this wonderful test, the benefit of this wonderful test that we thought was going to change the game for the given illness or the health problem. Now, when folks have studied this, and this comes from the REAIM framework, Russ Glasgow, who was at the MCI before me, with others, had developed this, what we basically come to is it's not just the effectiveness of our interventions. We've made a lot of progress in moving beyond the pristine efficacy trials as we've seen some of the messiness of the real world. But it's not just effectiveness. We need to think about reach. We need to think about the adoption of our different innovations. We need to think about implementation. And we need to think about the M as maintenance or sustainability. Can we sustain the things in care that we know to be effective? When Russ had looked at this kind of a scenario for certain health conditions, 6% would have been great. It was like 0.03 when it was looking at the community penetration of some of our evidence-based interventions. So we need to do better, and we start by focusing on these not just as decisions that we need to make, but maybe questions that we need to ask in a research context. So the key terms that we deal with are both implementation science, which is the name of our team here at NCI, and dissemination and implementation research, which is how we framed this for a while in a number of our NIH activities. So implementation science, as you can see, is really about the study of methods to try and integrate research findings, evidence, effective interventions into healthcare policy and practice. We define healthcare pretty broadly, so we have clinical as well as community settings, anywhere where someone's health could potentially be benefited. We also talk about dissemination and implementation research, and that's because on the dissemination side, remember, our classical efforts of disseminating evidence through the publication don't necessarily meet all those who we think might benefit from the research. And dissemination research is really about changing the game, making it better, making it more likely that evidence gets to those who could benefit from it and helps them in a way so that they can apply that evidence to better health and better health care. And then implementation research is really about how do we develop these strategies to adopt and integrate a whole range of different interventions in the specific settings where they can best be used. So as we think about Lynch syndrome, again, this isn't saying anything different from what I've been hearing from a lot of the talks thus far. It's not just about identifying that we have high-risk individuals, would we be able to capture them? But it really is on the implementation science side of trying to identify those strategies that are going to help us with the identification of Lynch syndrome within the broader population of those with colorectal cancer. And as was mentioned, even beyond that, it's thinking about what are the right strategies to improve scale-up among different family members. What are the right ways to not assume that the end point was that we identified people, but what do we do in the long term in terms of implementing ongoing screening, ongoing monitoring, treatment, et cetera. And importantly, as was mentioned several times, it's about the workforce capacity, it's about the training needs. How do we figure out how best to staff up our broader community of providers, of families, et cetera, of all those who might be able to make this a reality? And these aren't trivial considerations, but they're the things that we want to develop strategies on the implementation side to hope for, or to advance. When we think just briefly about precision medicine as a whole, it becomes really interesting because we have this opportunity to see, and I think it was mentioned certainly any number of times, of how fast our evidence base is changing. We have an opportunity to really think about what does it mean to try and create a healthcare system where clinical practice can incorporate all of these ongoing findings. There's any number of iterations of guidelines, there's any number of new studies that are coming out, and we haven't really thought about the dynamism here, and we haven't really thought about the opportunity to implement a healthcare system that's able to take advantage of all of these different findings. How do we think about implementing evidence that isn't static, but that's evolving over time? And how does the system that we develop actually expect that there are going to be changes on the horizon, and the decisions that we have to make may need to be remade again and again and again, and not assuming that the latest and greatest is the last that we will ever expect. Again, we really need to be thinking about the workforce, about the financing, ways in which this kind of care can be provided. It's not trivial, of course, as all of you have known and you've said much more eloquently than I am. It's incredibly important not to lose sight of what it is that needs to be implemented. Throughout the course of the day, I would say that we've heard a whole range of different things that are part of this intervention package that we need to think about if we're trying to optimize care. Is it the testing on one level? Is it ways in which we need to educate various stakeholders so that we can pave the way for more knowledge and ideally more awareness of sort of what's available to identify and then improve the lives of folks with Lynch syndrome and other hereditary cancers? We need to be thinking not just about that initial test, but about monitoring and follow-up. What is preventive care? What is treatment? Is our what, in this case, all of the above? And if it is, that of course is a pretty significant task. But starting with what helps us then to say, how do we get that in place? And it's very important not to jump over what. So when we think about studying implementation, this comes from 2009, a paper that Enola Proctor and others had pulled together. Basically, what we're trying to do in implementation is contrast or go that next step beyond just the what, but it is important to start with the what. The quality improvement efforts or the empirically supported treatments, evidence-based practices that you see on the left, and the cascade that gets us to better health outcomes at a population level. What we are used to dealing with in a lot of our research, certainly interventions research, is the left and the right. What do we do when there's a specific patient or a person in front of us and we're trying to maximize their health outcome? Most of our trials, or many of our trials, are really focusing on that sort of outer end, right? The what is it that we deliver if all of the circumstances are in place so that that person has access and can benefit from that particular intervention, and then what are the health outcomes that they're likely to generate: improvement in health status, reduction in symptoms, improvement in satisfaction and functioning. With implementation, we're really thinking about not just the what, but the how, right? How do we get that care delivered to everyone who can benefit from it? And we've identified a set, and you'll see it right here, a set of specific outcomes related to implementation that says, have we done a good job? Have we developed those effective strategies that are going to enable these evidence-based practices, these tests, the follow-up, et cetera, to be delivered? The idea through implementation science is that by focusing on the how, by focusing on the implementation strategies, and by succeeding in getting higher rates of adoption, higher rates of implementation, higher rates of sustainability, we're going to improve the service systems, which are caring for patients, families, et cetera, and then at a knock-on benefit, if we can improve the service systems, we're going to improve health outcomes not one person at a time, but at a population level. So if we're successful, it's moving beyond the usual to really think about the core of implementation research as how are these strategies getting us to effective implementation, but then if we're successful, seeing that it cascades outward. So another type of cascade, really thinking about what do we do at that system level, at that population level, so that we're not just relying on what was achievable through our earlier research, but it truly becomes standard care for all. Over the course of years, and folks in the room have been responsible for this, we've seen further sort of refinements to how we think about translational research. 15 years-ish ago, we were very much focused on these two big building blocks of translation. Translation one, from basic to clinical, and then everything else was trying to say, how do we take this clinical application and get it into practice? Over time, and you'll see Muin Khoury's and others' graphic in the bottom right, there's been a recognition of additional translational hurdles. Also, over time, I think we've been a little bit better of not seeing this as strictly a linear process, but saying, what can we learn at each stage of research that's going to help us with that next step? Can we be thinking, and this would be the challenge hopefully for others to take on as well, can we be thinking more and more about implementation earlier and earlier in the process? So the good news out of a lot of the efforts of people who have been engaged in this area for the last 10, 20, 30, 40 years is that we have a lot of models. Now, George Box is attributed, this quote is attributed to him, that essentially all models are wrong because they're simplistic, right? They're simplistic representations of a much more complicated universe, but some are useful. In the implementation science space, we have at least, this is, and counting, 61 and then some conceptual models that we think are probably wrong, but definitely useful. So we did a review in 2002 and just started out with trying to capture all of the different conceptual frameworks that have been developed to try and say what goes wrong and what goes right if we're taking evidence and integrating it within practice. And then we tried to say, is that more about information dissemination? Is it more about trying to take particular interventions and get them implemented? And we tried within this paper to give some guidance as to how does one choose a model. I'm going to very quickly mention a couple of them. One of them is an oldie but a goodie, Everett Rogers' Diffusion of Innovations, which came out of agriculture, basically started out by looking at farming practices and how farmers taught one another the different ways in which they could optimize, I guess it's productivity with seed corn, and it was very quickly applied to health interventions. What's very nice about this is that it focuses on, as we said before, the what are the characteristics of the intervention, and how does that make it more easy or harder for it to be implemented, and then it recognizes that there's a cascade of decisions that need to be made, decisions to adopt the intervention, decisions that will result in more effective implementation of that intervention within the system of care, and then importantly, what are the outcomes at different levels that are going to be generated from that. It also importantly focused on, whether we're talking about a hospital, we're talking about a clinic, we're talking about a community, there are characteristics of that setting that are going to be very important in determining whether we're successful in this process. And importantly as well, that there's this whole broader environment that we have to keep in mind. Context being important came up again and again today. And just to let you know, from the beginning, the theorists, the folks who are thinking about implementation have that front and center because it is so very important. An even more complicated slide that you probably won't be able to read, at least I probably can't from here, but you may not from the back, was a framework that Greg Ahrens and others developed in terms of mental health services, where they talked about 4 major stages that if people are thinking about implementation, they need to go through and they need to plan for. From exploring the idea that a particular intervention should be implemented through to preparation for it, the active implementation stage, and then the sustainment phase. And again, very important that we think not just about initial implementation, but about sustainment over time. And again, these frameworks are helpful because they point to many of the same concerns that have been raised over the course of the day and likely into tomorrow. So just to let you know, this is our chance If you want to ask and answer these questions, have we got the funding announcements for you? Across NIH, we have program announcements that are specifically devoted to dissemination implementation research studies that most of our institutes and centers at the NIH are involved in, and genomic medicine, methods development, system science, a whole range of different priority areas are there for the taking, and I think with pretty much each and every talk, I heard questions, I heard comments that very much fit what we're looking for. Namely, how can we think more about the sustainability, in this case, of different genetic testing, follow-up, cascade screening approaches? How do we think about how some of these tests are adapting or evolving over time? More on that in a second. Not just thinking about interventions one at a time, but what is our evidence-based system of care that gets someone from the starting line, to, starting point to a long-term evidence-based care being provided? What are the ways in which we can learn more from innovative dissemination strategies? And how do we not just think about implementation at that local level, but exactly what many of you have been talking about? How do we scale up effective practices across health plans, systems, networks, states, nations? Importantly as well, we want people to not just be thinking about bringing more and more in, but how do we take out those things that are no longer effective? How do we de-implement, exnovate, there are other terms that have been used, but how do we think about all sides of this implementation picture? We have a number of growing resources, we have training programs, we have hundreds of trainees, some of them are in the room, who have said, this is the type of science that I want to do, and it would be great to figure out ways to foster those partnerships so that, again, many of the questions that have come up can have answers, can have solid expertise around them. We have journals, we have a whole set of measurement tools, we have annual D&I science conferences. It would be great to think more about how do we build the space of implementation science for Lynch syndrome, for hereditary cancers, et cetera, more than we have already. So I'm just going to finish up with a couple of maybe challenges, moving beyond the traditional assumptions that I would love to see some consideration so that we don't continue to reify some of the things that haven't worked in the past. Traditional assumptions, as I see it, are that evidence-based practices, that interventions are static. Once we've captured them, we've manualized them, they're done, we're moving on. The systems, we know the systems. We know the systems within which we work. Once we know them, we'll always know them. That implementation goes sort of one practice, one test at a time. That consumers and patients are homogeneous, and that choosing to not implement is irrational. I'll say that most of the people in the room, and myself as well, would not necessarily assume these things, but I will tell you that most of the research that we have seen, at least even in the implementation science space, has suggested that these assumptions are still pretty true. We've got our manualized intervention and we know our system, so we're going to go forward with this one particular test or this intervention. So I think we need to ask that question, particularly as we're thinking about scale-up, might it be rational not to implement a given test or a given cascade screening, et cetera, within a certain population or a certain setting? Does it fit or does it not fit? Again, I think we should relax the assumption to assume that everyone, every circumstance is appropriate for every single intervention that we have created or innovation that we've created. It's really important not to assume that we've got a fit, but actually to try and assess that fit. Does anyone quickly know who this is a picture of or what this is a picture of? The Beatles. Thank you. This is the Beatles. If you just look at their hairdos, their haircuts, from 1963 to 1970. The point that I want to make here is that often when we're thinking about sustainability, we're thinking about things remaining exactly in the same state as it was initially. I think what people who follow the Beatles, like myself, would say that evolution in this case was good, that the music evolved, that the hairstyles evolved, that they adjusted to their circumstances and they learned and they got better over time. We don't necessarily ascribe that to a lot of our health interventions, and we may be limited by that. Last one, on the left side, those of you in the front should be able to see, it is Spock, right. So this is Spock when he's happy, when he's lonely, when he's jealous, when he's sad, when he's angry, when he's joyous, envious, etc., right? On the right side, anyone know who that is? Johnny Depp, right. So Johnny Depp, right. So this is the contrast, right. So the Spock idea is that no matter what the circumstances, you have pretty much the same intervention. In the other case, what you see is ongoing adaptation. You see for every different circumstance, there's a slightly different way in which that performance, that intervention is delivered. We need to be thinking about, rather than saying that it's either one or the other, we need to take on board much more understanding of what can be adapted, what should be adapted, what needs to stay the same. And so this fidelity versus adaptation, which plagues, I think, at least our field at times, needs to be moved beyond and really think about what are optimal adaptations that need to happen. So you'll see these questions as we go through the other presentations, but just to sort of prime you, these are the kind of things that we would love to engage you in discussing, and we would love to brainstorm with you. How can we take what we've already learned in implementation science and move it forward, and how can this be a really nice example to learn as much as we possibly can? So that's my pitch. Thank you for strolling with me on it. And now I will turn things over to Juan. So thanks very much.
Afternoon. So I'll ask you to recall a slide Lisa Richardson presented this morning. I know that was at like 8:30 this morning, so my apologies, but she showed a little timeline of kind of genomics programs that CDC has funded over time. And so I'm going to talk a little bit about one of the programs we're currently funding and one of the things we're currently doing, or some of our states that we fund are currently doing. So we have a cooperative agreement where we fund state health departments in 5 different states, Michigan, Oregon, Connecticut, Utah, and Colorado, to implement strategies in cancer genomics, and so that we can kind of do exactly what David was talking about. How do we actually put these guidelines and these recommendations into practice? And so then that we look at our state programs as kind of laboratories for implementation, so that we can try to figure out what works, what doesn't work, and then how that could work in other settings or other situations. So our states do a lot of different things. They do public and provider education. They do basic surveillance work. But one thing they do have in common across all 5 of our programs is that they all try to use state cancer registries in ways that go kind of beyond basic surveillance or basic ways of assessing cancer burden. And that mostly came up because all of our programs are trying to really answer the question, how do we identify high-risk individuals on a population-based level? And so, they're not necessarily working in clinics, they're not necessarily kind of providing direct patient care, as Deb kind of mentioned during her talk today, but they are trying to kind of work at a population level to identify high-risk individuals, and that's kind of where work with our state cancer registry started. And so I'm going to give a very brief introduction to cancer registries and cancer registration. I'm going to do a massive disservice to both the programs NCI and CDC fund, but just in case there's someone who doesn't have a very strong kind of background or even a general background in cancer registries, just to kind of get everyone kind of general lingo terms. So there are 2 federally funded cancer registration systems. At the CDC, the program is called the National Program of Cancer Registries, or NPCR, and at NCI, there is a Surveillance, Epidemiology, and End Results Program, or SEER. And so together, these 2 programs collect data on cancer cases for the entire nation and several U.S. territories. So this data enables our agencies and the public, since most of this data is publicly available, monitor the cancer burden, evaluate the success of our programs, and identify needs for cancer prevention and control efforts. Now, our registries, they collect different information, but there are minimum data standards that our registries collect across each state across each state program. Generally, every registry collects data on patient demographics, primary tumor sites, tumor morphology and stage, and first course of treatment. And so having this kind of data, this kind of population-based data at the state level really presents an opportunity for public health cancer genomics programs to leverage registry data to identify individuals diagnosed with cancers that may have a hereditary genetic component. And so this is usually done by states kind of setting some sort of by kind of making decisions on what will be classified as a hereditary cancer. So examples are so that they can assess all breast cancers diagnosed under age 45, for example, all contralateral breast cancer cases, anyone with a history of both breast and ovarian cancer, any colorectal cancers diagnosed under age 50, or all colorectal cancer cases diagnosed. In the case of Lynch syndrome, endometrial cancers under age 50, or all endometrial cancers. Our programs have kind of different cutoffs they use for some of these things. And so in the case of Lynch syndrome itself, some of our registries also collect information on IHC, testing and MSI status, but that information is not necessarily collected as routinely across all state registry programs. That information is also a little harder to find in electronic medical records because all registry information ends up is extracted out of medical records and maybe a little harder to find. So routinely finding some of those details in registry records are a little more complicated. Similarly for BRCA testing status or mutation status, some of that information, some registries collect it, some don't. So we don't necessarily have kind of national data on some of that. But we have our states use two primary methods for identification of individuals with suspected hereditary cancers. They either work through the physician or institution, or they kind of go directly to the patient. And so I'll kind of break those down individually. But what I mean by physician or institutional reporting, a lot of our states call that bidirectional reporting. And what they essentially do, I created kind of these rough flow charts of how this kind of usually works, is that the physician or reporting institution send the diagnosing information or the tumor information to the state cancer registry. The state cancer genomics program extracts relevant cases based on the definitions they've set from that registry, and then they create reports that they send back to either the reporting physician or the institution. Now, these reports can kind of vary depending on state policies related to privacy and confidentiality of registry data, but usually on a very general sense, they at the very least include aggregate information on the number of individuals diagnosed by a particular provider or by a particular health center or system with the suspected hereditary cancer. So you've diagnosed in the last year X number of patients with these kinds of cancers. They usually let them know at the state level how many were diagnosed with those diseases, with that same disease, and then provide information on, in terms of genetics, how that patient that these patients would have been ideal candidates for referral to genetic counseling and testing solely based on their diagnosis information. Family history is usually a field not available in cancer registries, so any kind of determination of whether someone may or may not be high risk for hereditary cancer is solely based on the primary diagnosis information. And so these reports tend to go back to the reporting physician or the institution to kind of let them know, hey, in a given calendar year, these are the cases you diagnosed. And also with the packets are usually included information on referral to genetic counseling services that providers may find useful. They also provide educational information to both the physician and for physicians to share with patients. Sometimes, and depending on state policies, some of our physicians can receive identified data reports where they're actually able to put the name, birth date, and potentially some contact information for the patient, so the doctor has the ability to refer back to a specific patient case. So the benefits of this kind of method are that it identifies patients who are potential candidates for genetic counseling and testing at a population-based level within a given state, and this kind of does provide a new opportunity for implementation of cascade screening efforts. However, it does present some challenges, as we've discussed before. Only relying on individuals already diagnosed with cancer will leave a lot of relevant cases left out. The provider or institution in the registry may not have been involved in the treatment, since abstraction of medical records for registries don't necessarily happen at every state, and several times over the patient's process you could have been diagnosed somewhere but then received care somewhere else, or you could have moved to a different state, so your information would be in a different state cancer registry. There's also a lag time usually between diagnosis, registry entry, and by the time the program can extract data. Those lags could cause a potential provider to not want to reach back out to a patient. So if they find out 2 years later they should have recommended genetic counseling, they might be hesitant to reach back out to that patient. And if you're reporting back to a health system level, recipients of reports and dissemination plans may vary by institution. So who at Kaiser Permanente, for example, should receive this report. You have to really make sure you've identified a champion in that healthcare system, have a partnership of some sort with that healthcare system to know who to really send that information to. Some of our states anecdotally have reported that as a system intervention, this hasn't necessarily been the most effective, but that it has been effective as an educational intervention for physicians. A lot of times, our programs have been invited to present the results of kind of some of this work at tumor boards or grand rounds, so they kind of have an opportunity to educate doctors when there's a captive audience on on some of these cancer cases that might have benefited from genetic counseling and testing, but we do also have some examples where health systems, just by being educated, or physicians, just by being educated on the cancer cases that they should have probably referred to cancer genetics, they make them question their systems associated with this sometimes, and Heather alluded to this earlier. It's really about realizing the burden that you might have, or how popular those services might be that might make you actually stop and think, well, maybe this is something that we should be looking at in a different way than we have been before. That's especially been true for some of our community hospitals. Then the other system is really patient-level reporting, and this is not something necessarily. This is a system that many of us are kind of used to, especially anyone who's done patient contact research through a registry, or anyone who's done caregiver research is probably pretty familiar with this, where we, instead of kind of the state cancer genomics program reporting back to the reporting hospital or institution, they kind of goes directly to the cancer survivor and then work with the cancer survivor to kind of contact relatives who may also benefit from cancer genetic services or from increased screening services. Depending on state policies, there might be a step in between the state cancer genomics program reaching out to the cancer survivors themselves, where they might have to get a physician consent process kind of put into the system in order to contact the patient. And so the way this usually works is where the state genomics program encounters the cancer survivor, works with them, does a pretty intensive interview to get a sense of family history of cancer, if any cancer genetic services were part of their diagnosis process or their treatment process, and then work with them to kind of identify family members based on the pedigree information that was collected in order to really see if there are certain key relatives who might be beneficial to kind of bring them together, and then kind of follow protocols similar to what Heather talked about, where you kind of try to get that captive audience together, the patient and their relatives, in order to kind of talk through the family history of cancer, what the risk level for the family might be, and who in the family might be ideal candidates for receiving genetic counseling and testing. Similarly, this also identifies patients who are potential candidates for genetic counseling and testing at a population level, and it really has significant opportunities for improving cascade screening efforts, since you have a captive audience of the survivor and their families. But also similarly, there are several challenges. It is hard, like I said before, to identify all relevant cases. The lag time and availability of data in the registry becomes potentially more of a concern now, because you're trying to reach out to patients 2 years, potentially post-diagnosis, and they might have a lot of questions or issues associated with why this wasn't talked about when they were in the diagnosis and treatment process of their cancer, if it wasn't brought up. This does require much more significant resources, for especially a lot of our state health departments that have engaged in these activities. It's necessitated additional funding than what we're normally able to provide, and it's really necessitated partnership with large academic institutions in order to kind of have the infrastructure to kind of manage a study of this size. IRB-approved research protocols are needed, especially for programs like ours that are mostly based on implementation. A lot of the IRB needs of our programs are often kind of put under public health evaluation, so it's not as a stringent research protocol approval process. But for studies like this, you can't just send out health education materials to a list of people who've been diagnosed with cancer. Most states do not allow that. You need to have some sort of research protocol involved. So the sustainability of an activity like this over time, you have to wonder how many research protocols is a State Department or a university kind of going to go through doing the same thing kind of over and over again to try to keep this moving. And also the burden of communicating risk to relatives is kind of solely left to the cancer survivor, as we discussed earlier today. They might be able to receive some coaching from a genetic counselor or someone on the research staff before kind of reaching out to their relatives, and they're certainly given the ability to get materials, but it may be difficult these are difficult conversations potentially to have for patients in their, with their family members, especially if there are family issues or family communication problems. And so just kind of leaving the onus on the patient can backfire and can make the cascade screening efforts not as productive potentially. And also, if anyone else has ever been involved in contacting people from a cancer registry, there can be alarm at the existence of a cancer registry. I myself have been involved in several studies where we contacted patients from cancer registries, and not everyone is excited to know that the federal government knows that they were diagnosed with cancer. So in summary, cancer registries present an opportunity for cancer genomics programs to identify high-risk cancer survivors, either through physicians, healthcare systems, or their patient and the family members. While these methods have the potential to increase appropriate utilization of genetic counseling and testing, further work is needed to better understand how to implement and evaluate these activities. Evaluation of this work has been significantly challenging because it's difficult to figure out who you survey at a health system, and doctors aren't the greatest at returning surveys. So we have faced a lot of challenges implementing this. Challenges and limitations of these methods may make it difficult for timely implementation during the diagnostic treatment process. That's this lag I've been talking about from the data, when the patient gets diagnosed, so you see the data in the registry. But hopefully through the work of our 5 grantees, we'll be able to clarify some of these questions. You'll be able to push the envelope a little further in this over the last 2 years we have left in our funding cycle. All right, thank you.
Good afternoon, everyone. Thank you for the invitation, for allowing me to share some time with you this afternoon. So I wanted to focus a little bit more on the workforce potential for genetic counselors and talk through some strategies in which we might begin to meet the future demand. So let's go through a little bit of background. This data is coming from the 2016 Professional Status Survey through the National Society of Genetic Counselors, and the picture is showing you the wide variety of subspecialties that genetic counselors work in and the various work settings as well. The number I do want to highlight on this slide is actually that in 2016, there's 48% of the genetic counselors that are specializing in cancer genetics, which is up from 29% in 2014. We've worked hard to develop multiple service delivery models because we understand the need for access in various geographic areas. So we've always used the traditional face-to-face consultation, but we've expanded into using telephone and telegenetic, which is a combination of telephone and computer, as well as group sessions and using some interactive technology to help fit the different educational needs that the patients have. Early data suggesting that there's comparable satisfaction regardless of which model it is that we're using, so this is a nice way to help reach a further audience. When it comes to framing the workforce issue, this is a difficult concept to try to tackle, and there's multiple facets that NSGC and our sister organizations had worked on to come to this conclusion. So let's start with improving the utilization of current workforce. Right now, there's 4,140 board-certified genetic counselors in the U.S., and there's underutilization of their services. We have existing capacity that could be improved upon. Part of that is lack of education about how to find us and where we're located, both on the part of the public and as well as referring providers. So there's 2 tools that can be used. One is through nsgc.org, and the other one is the brand new consumer website that is aboutgeneticcounselors.com. But if we have access then to utilize these alternate service delivery models, genetic counselors tend to be in the larger metropolitan areas. That means that people who are in rural areas have the ability today to access genetic counselors if we can get them connected. But we've also learned in this process that availability alone does not lead to appropriate access to genetic services. Part of what we're dealing with is still under recognition and under referral of the patients, and that's a big contributor to the problem. When it comes to accessibility, I thought it would be good for us to start historically. In the 10 years between 2006 and 2016, the profession had an 88% growth in the number of genetic counselors. That's really good growth. Most genetic counselors are reporting that they could see a new patient within a week, and if there are stat consults that are needed for immediate surgical management, the vast majority of genetic counselors were saying that they could accommodate that request in 1 to 2 days. We've also focused on efficiency efforts because it's very important for us to take and maximize the efficiency of our current workforce to increase those patient volumes, yet maintaining high-quality care at the same time. So we've explored electronic tools and creating some interoperability so that we're not doing redundant data entry to be able to complete the risk assessment and that consultation. And a systematic way to collect family history would be important because oftentimes those pedigrees on an easy, short pedigree will take about 15 minutes. Easily that can go to 30 minutes depending on the size of that family tree. Having that information up front can save a lot of time because we're only updating and dedicating our time to the conversation instead. We also need to improve administrative support so that genetic counselors are focusing on the work that is specific to their unique skill set. We need to move away from doing scheduling and secretarial or administrative tasks because there are other people that are very skilled at being able to accomplish those tasks. And then streamlining the EHR function so that we can house the genetic information, do the queries, and again, create that interoperability. There are access barriers, and I'll focus on lack of Medicare recognition and state licensure more in a minute, but reimbursement for services is a significant problem. There are areas throughout the country where reimbursement for the services is a covered benefit, but it's not consistent across the country. So there's work that needs to be done so that patients can have access to that service. and also working with the payers to create an accurate provider registry. Many times, the provider networks are too narrow. The payers are contracting with one given telephone company, for example. They may not be allowing their policyholders to utilize the genetic counselors that are local, so we're not able to capitalize on all of the different service delivery models that are available to reach those patients. It's also an access barrier because many of these registries do not have genetic counselors as a provider category, so the policyholders have a difficult time identifying who would be appropriate for them to go see. When it comes to the barriers to referral, I mean, we're busy clinicians. We know full well that providers have lack of time to obtain and assess the family history, and there's variability in the comfort level and the knowledge in genetics to be able to fulfill that task once they've obtained it. There's also a substitution effect, because traditionally there has been, it's been noted that there's a shortage of genetic counselors, which actually hasn't been true until about the last 3 years. Now we've got work that we've got to do. But the substitution effect, we've got providers who are desperately wanting to help provide access to their patients and offering that. Sometimes that's being done very well, other times not so much. But we think about what's happening in that clinical landscape. There's about 10 new genetic tests that are coming to the market on a daily basis, and the kind of complexity that goes along with those tests has gone up dramatically. So from a provider standpoint, unless they're able to input like concentrated effort on continuing education in genetics, it'll be very easy for the best intended provider to fall behind. The lack of CMS recognition is a barrier issue. We're working with Representative Paulson, who happens to be my representative from Minnesota. We do have a bill drafted that will recognize certified genetic counselors as providers under Medicare, and we've spent a lot of time working with other organizations gaining support for this. This is a place where the NIH and the NCI could also be of benefit for us in this process. The goal is to introduce the bill sometime during this session. State licensure has been another area where we've placed concerted effort. There's now 22 states that are actively, there are 22 states that have licensure, 19 are actively issuing, 3 are in rulemaking, and licensure efforts are ongoing in additional 26 states from having bills introduced to just starting that conversation. So at least across the country, there's work on licensure in 48 states so that we can be recognized providers in that capacity too. Then we have to think about the training. Right now there's 41 genetic counseling training programs that are available, and we've worked with the current programs to increase the number of students that are admitted to those programs. On average, that class size is currently about 8 students per program. The program directors are commenting that they've had a very significant increase in the number of unique applicants that are applying to the programs, and these are well-qualified people, but there isn't enough training slots to be able to invite them into the profession. So we have a robust pipeline of more people to help build the programs. And there's also work to ensure that accreditation and certification trends are aligned with the best practice in supporting the growth of the workforce. Then we need to think about new programs. There's been active interest in starting new training programs. There's 21 schools that have expressed interest in exploring the development of a program, and the new programs coming on are intending to admit much larger class sizes than the current availability of the programs. So if we're spreading the entry of those programs out over a couple of years, that gives us the opportunity to see a bigger increase in the number of genetic counselors, but also not overshoot when we're trying to estimate what is that demand for services. One of the bigger issues that we're starting to see now is clinical genetic counselors are having more and more demands on their time. So we need to be working with the employers so that the employers are supporting the ability of the clinical genetic counselors to train the students and be a rotation site. This is the part that I'm sure you were all really waiting for, and that is really how can we project the growth to meet this demand? So we've hired Dobson Devanzo, which is a consulting firm here in DC, and taking some of this data that we've talked about was trying to project what is the future growth of the genetic counseling profession in the next 10 years. They've estimated that growth would have been 72%. But in the first year since that report was written, we're already outpacing that by 6%. So this number is going to be pretty fluid because it is difficult to try to calculate. They've also looked at a couple of different models as trying to determine how many, for one genetic counselor, how many people do they need to be available for, and that's another difficult model. If we take the model that one genetic counselor per 100,000 people in the United States, we should reach equilibrium in 5 years. If we take the model that one genetic counselor per 75,000 people, the estimate is that the equilibrium will be reached in 10 years or less. So this is a gap, but it's a closable gap with concerted effort. I also wanted to provide some clinical perspectives on meeting some of the needs, and some of which I'm going to echo some of the things that were already said today, so I'll gloss over some of it. But we've all said that Lynch syndrome is not the only explanation for the cancers that we're seeing. And while people have talked about this before, I'm a clinician. A good family history to me is critical to interpret these test results. Without it, we've got an indeterminate negative, and we run the risk of false reassurance and the lack of utilization of risk reduction or surveillance options. And we know we've talked about the panel testing to test for other things, but this is, to me, is where the pre- and post-test genetic counseling is more important now than it has been. And we've talked a little bit about the cultural differences, because not all cultures value genetic testing in the same way. So we do have to be aware of the potential for stigmatization of results, transmitter guilt, and some cultures feel that this is going to be a detriment, not a benefit. So if patients aren't ready and they're not choosing to find out this information on their own time frame, they may not be ready to utilize the risk reduction or the surveillance options that are available. And we still have to deal with the pervasive racial and ethnic disparities between access to genetic counselors as well as the other specialists that might be needed, and access to quality care and follow-up. So if we identify the mutation, we need to make sure those patients have access to people to take care of them and reduce the disparity in their ability to pay for the care. When it comes to the public and the providers, we do have the risk of harm from misinterpretation of the results. We can end up with unnecessary surgeries, and again, that missed opportunity to take action based on that DNA test result. We've talked already today about the importance of cascade testing, but as a clinician, I'd like to see family history as another screening tool that needs to be revisited on a once-a-year basis, because as family histories change, we need to go back periodically and reevaluate that risk. And, you know, people need to understand that there's a potential that we will identify unanticipated findings, and particularly lately when we're talking about concerns on behalf of our patients between health, life, disability, and long-term care insurances, we need to be able to address those concerns, and until we can do that, it'll limit the uptake of the genetic testing. The systematic need, one of the biggest impacts across the board, regardless of subspecialty in medicine, is being able to systematically take a family history, because the vast majority of the time that's not happening, or if it is happening, it's not even to the point that we'd be able to triage it, let alone do a risk assessment. So collecting that base family history across the board will be a really good first step. Having a centralized database, because we can prevent the repeat testing, and a method to recontact people, because over time the interpretation of that result is going to mature as the data matures. And as people move through different phases of their life, what that result means to them will change over time, and we need to be able to keep them in contact with genetic services. And we've already talked about the clinical infrastructure needs. Earlier today, we had a brief talk about what is the process for genetic counseling, and I think there's several key questions that we need to be asking as we determine how would we implement such a project. Who would get access to care? Is it everybody, or is it only those that would test positive? And what happens to the participants that don't schedule the visit? Have we generated a liability on the part of the provider that we don't have the ability to connect with the patient? Who's going to provide the genetic counseling, and how can we ensure that they have the appropriate training to do that and be able to ensure that the interpretation of that result is in the context of the family tree? So when we think about the impact of universal screening on the genetic counselor workforce, if we're going to estimate that the care frequency is at about 1 in 279, I think we do need to think about large-scale ways in which we can provide education, because at the time of a cancer diagnosis or potential of an identification of an inherited risk, it becomes a crisis moment. So having real-time access, whether that be through a recorded video or electronic tools or different education materials that are quick and easy for the providers and the patients to be able to take home until they have the ability to have a further discussion with a genetics professional would be important. And we need to consider, again, the needs of the probands, because at the time of diagnosis, they're also very concerned about their relatives, and being able to get that cascade testing going, as Heather has alluded to earlier, is very valuable. Bringing down the access barriers, and this is something that I think we can all be working on together, because part of the access barrier is being able to accept that these alternate service delivery models have value, that they are a way, while it's not the traditional face-to-face, they still can connect a person one-to-one with a trained provider and be able to communicate that information in a timely way. It adds flexibility and convenience to the patient, frankly to the counselor and the referring provider, because we're able to see more people and bring down costs at the same time. So we've learned from talking with our patients and the consumers that we can't rely on just a one-size-fits-all model of how to disseminate the information. Not everybody learns in the same way. Some people are really going to prefer that one-to-one visit. Others will prefer the privacy that's afforded by telephone. And then others will, especially nowadays, they're much more comfortable with the interactive technology. They'd rather learn it that way than trying to go to another appointment. So when we're thinking about collaboration, this is something that's going to be important because our current system is not working. From multiple different data sources that we've approached to collect information over the past several years, we've learned that about 30% of genetic tests that are ordered by non-genetics providers are inappropriately ordered. And what I mean by that is that could be the wrong technology, the wrong gene, that person's not a testing candidate, or they're blending both sides of the family together in order to meet criteria. So that's suggesting that that providers are needing some help in being able to execute this process well. And we need to stop thinking about genetics as a boutique service and get that integrated into routine patient care, because it's something that impacts every subspecialty of medicine. So by working together, we can be providing and maintaining education, either from us providing the genetics, but also looking at the other subspecialties, you informing us, so that we're working together as a good, cohesive healthcare team for better care. So again, collaboration to me is going to be key in this, and it fits well with the Moonshot Initiative, because by working together, we can make a difference to benefit our patients, the healthcare system, and the population. So genetic counselors would be happy to take a leading role in the development, implementation, and the delivery of these services. We can enhance the team approach with our healthcare colleagues, and it's imperative that we're collectively doing a better job. Thank you.
All right. Good afternoon. Do you want to take a 1-minute stretch? It's been a long day for all of us. Stand up. Thank you. All right. First of all, I'd like to thank all of you for staying, because it's been a long day, and throughout the day, I almost changed my slides at least 5 times. But the good news is that after such a long day, everything that I wanted to say has already been said. But here are our discussion questions. What can we learn from other conditions, hereditary cancers, although the focus is on Lynch syndrome, workforce issues, implementation beyond genetic testing, and system level. So what I decided to do in my 5 to 7 minutes is to take a bigger picture approach. You've heard about implementation science from David. You've heard about public health efforts from Juan, and earlier from Lisa Richardson. And Lynch syndrome represents really the very tip of the iceberg for precision medicine. Think about genomic medicine with all the many, many genetic tests, panel testing, even whole exome, whole genome sequencing. What this intersection represents is sort of what we need. I'd like to describe to you that intersection. It's very small right now, but it's growing. And in order for precision medicine and Lynch syndrome in particular to succeed, we need that intersection to grow. As was alluded before, and actually Heather mentioned Tier 1 genomic tests and applications earlier. I don't think anyone knows what Tier 1 is. Part of what we do in our office at CDC is to try to help CDC program focus on where the evidence is, because there is a lot of hype about genetics. And people sometimes are, in public health in particular, are willing to throw the baby with the bathwater because they don't think there is any baby there. And so for the last few years, we focused our energy on trying to find those applications that are ready for implementation, and Lynch syndrome is one of them. There is a lot of stuff in the red. Actually, as a matter of fact, most genomics is still in Tier 3, not ready for application, but there is things bubbling up to the surface. And a few years ago, we had this workshop that identified the top 3-tier applications. Lynch syndrome is one of them, HBOC, and I want to use an example from the non-cancer world, familial hypercholesterolemia. No one has talked today about FH, but there is a lot of parallelism between FH and these other 2 cancers. All 3 conditions are autosomal dominant with high penetrance, and they're common. And in the US, actually that number around 2 million, maybe closer to 3 million, depending on what numbers you quote. The problem is most people with these 3 conditions don't know they have it. So one of the questions is, why not screen the whole population? We screen newborns, don't we? we're not going to do that. I don't think there is any evidence to do that yet. And Barry Kramer always has the right question about the penetrance and the natural history, because there is a lot of things we don't know about these conditions. But wanted to kind of revisit with you the three recommendations that are the basis of these three-tier applications. EGAPP was mentioned. And EGAPP has been really sort of a pioneer effort. Ned Kalange, who's the speaker tomorrow, was the EGAPP chair for a few years. And as a matter of fact, EGAPP was the first group to recommend universal screening for Lynch syndrome for colorectal cancer. NICE in England today released their recommendations for universal Lynch syndrome screening. Up to this point, they had an age cutoff. So we are 8 years through the journey from recommendation to practice. I don't think we are at 6% yet in terms of that benefit. So what we have to do, and even if we implement this recommendation, it will miss more than 2/3 of Lynch syndrome patients in the US. That number is back of the envelope calculation. And when Doug Lowy was here this morning, he made his own back of the envelope calculation, and he landed at 20%. Which is not that far, unless you start doing cascading beyond the nuclear family to cascade to first, second, third, fourth, fifth generation. And, you know, Heather is shaking her head there because the more relatives you get, the more cases you will find. And that experience we have in the Netherlands for cascade screening for FH, which we don't have in this country. Just a word about BRCA. We've seen the recommendations, and they're all family-based. There is no recommendation for universal screening in the population, although people like Mary Claire King would love all women to be screened. And Joy and I had the chance to debate her at the last National Society for Genetic Counselors meeting. But Mary Claire is right. If you implement the U.S. Preventive Services Task Force recommendation, you're going to miss more than half of people with hereditary breast and ovarian cancer due to BRCA1 and C2 mutations. NICE in the UK was ahead of the US with respect to FH because we don't have US-based recommendations around familial hypercholesterolemia, no matter how much we tried to influence the task force. As a matter of fact, I mean, they recommended cascade screening in 2008. The last task force 2016 around familial hypercholesterolemia concluded with the following statement, and I want to read it because it applies to cancer. Cascade screening was excluded from this review because of its limited relevance to the current U.S. primary care practice, but it may be a promising strategy for FH case finding, especially as genetic testing evolves. Cascade screening is a wonderful concept, but it's very hard to implement, but we shouldn't give up. So what did we do from 2009 to 2017? How do we accelerate this process? So the first thing we did was to convene that meeting back in 2011, which Deb Duquette mentioned, as a result of which the Lynch Syndrome Screening Network was created, and you've seen some of the results from that. The other meeting which the NCI put together is this multi-level intervention approach for the cancer care continuum. That was a special supplement to JNCI that was put together back in 2012 based on a series of conversations and meetings, and there is an RFA on the street right now that shows that in order to implement anything in cancer care and prevention, you need to look at all these levels, and you need to look at them together, not just one at a time. At that time, one of the papers was presented, and I had the chance to work with many people to write about the multi-level research and the challenges of implementing genomic medicine, was part of that conversation. And we used Lynch syndrome as an example, even back in 2011. You can't see all of this stuff, but you can go back to the paper and see how the factors that impede or facilitate the implementation of finding cases and cascading to relatives and implementation. And you've heard about all of these examples of factors earlier. And some of the studies that were presented and are in the literature look at that. But let's explore this intersection between implementation science and genomic medicine. David and I had a chance to work with Megan Roberts, who is in the back, a fellow at NCI, and Amy Kennedy, who I'm not sure if she's still here anymore, to actually review the literature on that intersection. We took 1 year of data from PubMed, which is about 100,000 genomic publications. And we found only 283 articles that meet the definition of implementation science. That's about 0.28% of the genetics literature is implementation science. Half of it is most relevant to cancer. There were 12 articles relevant to Lynch syndrome. So Lynch syndrome is an active area of research. But some of the common features of the current published implementation science in genomics is really has room for improvement. Only less than 2% of these studies integrated these implementation science frameworks. Most of the studies are based on the individual rather than systems or providers. As you heard the whole day, you know, in order to do proper implementation and dissemination, you have to include all these levels. Majority of published studies were done in academic medical centers. And you're going to hear from Greg Firu tomorrow about sort of the real world out there outside academia. Fewer than half of the studies included information on race and ethnicity, challenging our issues around disparities and generalizability. Majorities of studies were in oncology, which is fine in this case, but there is plenty that's going on outside oncology. Most studies are observational. There is very little in terms of strategies for experimentation with implementation A versus B, for example. And few studies reported on the use of collaboration, which is a key metric in order to succeed. So I want to end up with sort of a shout out here. I don't know why this is coming like this, but let's, okay. So for the last year, we've been exploring through the National Academies of Science, Engineering, and Medicine. It's a mouthful to say. I used to love the IOM, it was much easier. We created a new action collaborative, Genomics and Population Health, which is what I call an example of precision public health. We are focusing on these three conditions, finding ways to try to scale up the implementation using the public health healthcare interface. You heard from Juan that 5 states are being funded to do Lynch syndrome work, about the other 45. Are the states working with their, you know, all the partners? You heard from Michigan earlier. So we have 2 working groups, and both chairs of these working groups are here. Nat Kalange, who you'll hear from tomorrow, is in charge of the evidence working group, reviewing what kind of evidence does public health and population health planners need for action. And the one thing that we, you know, coming from a world of public health, people always tell me, line up. There is a whole slew of activities we need to do in public health before we get to genomics. And I have to fight my way to the table telling them, but look, there is 1 million people that need to be found, and we can save X numbers of lives every year, and it's cost effective, you know, with this kind of metric or not. And the second working group is chaired by Deb Duquette, and Heather is also part of it, and there's other people involved here, is to try to, you know, do the landscape of finding who's implementing, developing the tools and metrics for success. And what we're going to do this year, I think one of the things that is really ripe for studying using implementation science framework is study the science of cascading. Because cascading, and we heard from Patrick Lynch this morning, is not easy. And there has to be a way to study it, study the best approaches to it, because the more we find relatives, the more we're going to get to that 1 million person who have Lynch syndrome in the population. And last but not least, I think we're going to have to study the feasibility of population screening, whether actual and opportunistic. And what's the difference between the two of them? The opportunistic population screening is the Precision Medicine Initiative. All of a sudden, we're going to have millions of people with their sequence in hand. So for these people, we can study by returning the results of at least some of these genes to figure out who has these diseases, are they part of the system, how can we reach them with the proper services. So with that, I'm going to turn it to my friend, David Renzahoff, for further discussion. Thank you.
Well, thank you. This has been a fascinating day. It has been very intense. Luckily, as Mouine said, we've heard just about everything that anybody can say. so I'm going to be very brief. I have just about 6 slides total. And I wanted to select, let's see, next. You know, if it's not a Mac, I just don't know how to do this. Good. Now I can do the arrow, the down arrow. Thank you. All right. Okay. So I want to talk just very, very briefly about one topic that we've heard some about today. We've talked mainly about cascade screening, and I want to talk a little bit about beyond cascade screening. This and why this might be important to keep on the radar of this field. This is not the main topic of the Blue Ribbon Report. If you look at the 74 pages, stuff about non-cascade screening or population-based screening does appear in the supplemental material. So it's on the radar somewhere. I just want to make a case for having this somewhere on the radar. And the topic, right, down arrow, thank you. Where is it, the down arrow? Okay, all right. There we go. So this relates to our discussion questions about implementation very broadly. Here's the discussion questions here. And what I want to focus on, just for a minute, again, this is very, very brief, is can we go beyond cascade screening for Lynch and other things like BRCA and other things where there's strong mutations that relate to risk? And the question is, what's the colon cancer risk associated with Lynch mutations in the population, not in families with Lynch cancer or BRCA? And the importance of this is that precision testing by genetics, this is what we've promised to the public and what they expect. Now, that doesn't mean that we can deliver this to the public, but when they think about genetics and precision medicine, this is basically what we have held out to them. It's deterministic. And 50% of Lynch cancers, or 80% of Lynch cancers, or 20% of Lynch cancers are missed. A lot of Lynch cancers are missed by cascade screening. And mutations found in primary testing, if they're acted on, because we get them from 23andMe or whatever it is, these things can cause mischief, meaning major operations, major worry when people with the gene for long QT and sudden death go to their cardiologist to say, I'm going to die, do I need a defibrillator? There's serious stuff that's going on here, and we're messing with people's lives. And if we had reliable risk data, that could allow population screening. And I was fascinated this morning when it was Barry Kramer asked during one of the panel discussions, he said, okay, let's pretend we've got a person who's got a Lynch mutation, but they don't have a family member with cancer. What's their absolute risk over a lifetime? It took several hours to get to that point where we're talking about numbers, what is somebody's risk? And the answer was, we basically have no idea. And that by itself is fascinating. Rick Boland then said, well, I think I can speculate about what some of the other mutations or problems are or features about why there's this huge spectrum of penetrance, but this is a really, really serious problem that gets in the way of our having reliable risk data, not for people with families, but for people without. Is there a way to address that? And there was some talk about that this morning. This is not a new problem. This is being studied for BRCA in the UK and so forth. It's on people's radars. It's hard to study. But is Lynch one of the things that would let us study this more easily? Should I press the down button? Yeah. Okay. Yeah, see? All right. We're nearly done. Implementation strategies would differ from cascade screening for hereditary cancer, and this is a future topic. We're talking about implementation now. The implementation scheme would be substantially different if we did this. And this is now the last 2 slides, and then I'm done. I just want to put this more on people's radars. Again, I know it's already there. The importance of putting this problem on our radar, and the conclusion of this tiny little few comments is, Lynch, if anything is a poster child, Lynch should be the poster child example for population screening. It's an autosomal dominant. The colon cancer risk can get very, very high, and it's easy to intervene. We're not doing radical operations on people. This is a fairly easy problem. And this is the last slide. If we can't figure out population screening for Lynch, then how can we implement testing and follow-up for more complicated or more subtle risk? And I'm wondering, you know, if somebody was king of the world, you could suggest to them, let's really study the heck out of this problem and BRCA and figure out, like for Mary Claire King or whoever, what can we really do in population-based screening? Because if we can't figure it out for these problems, we're going to have a real hard time figuring it out for others. I was struck, too, by Dr. Brody's comment today earlier saying, you know, maybe these things are really extreme one-offs, and we've even got problems using them. What does that say for the whole field? Last point is, if we can study this, we're going to learn interesting things about how hard it is to do, how easy it is to do, whether it's feasible. That's going to be useful clinically. We're also going to learn, like Rick was saying, really interesting biology. If we can understand why some people have bad outcomes and others don't. Again, this is not the main focus of the moonshot immediately in the 74-page report, but it's on the radar because it's in the supplemental material, just something to keep in mind. Again, this has been a fascinating day, and I've learned a lot and want to thank for being invited and participating. Thanks.
Okay, so I am going to put you back to the past. And the past looked a little something like this. Okay, so you have the panelists here. It is opportune time for questions, for comments. As you can see, a number of discussion questions that were touched upon by the different panelists. Feel free to weigh in, but also to gain more insights from their expertise. So Barry. So for those out in cyberspace, we are working on the microphone becoming live. And there we go.
You made a very good point, but it was a brief point about de-implementation, because the whole day we've basically focused on implementation, and the question is, if we accidentally and with all good intentions overshoot the mark, usually it takes years, if not decades, to get the pendulum back. And so I would just like your thoughts on what do you do to anticipate, you know, in case you overshoot the mark. If you overdo it and you learn something that you've incurred a net harm, if you haven't already thought about it and done research on it, then you're starting from a standing start when the null hypothesis has already been set and tends to stay in place for years and years. So do you have any thoughts on should we be anticipating that and planning research in that direction?
Yeah, so thanks, Barry, for that. Yes, I think we should be far more willing to take advantage of ongoing natural opportunities to see and to try and actually encourage and assess the need for and for de-implementation. Most any time that we're implementing something, we're often needing to substitute or need to take something out. And I don't think we really, at least a lot of our studies, are kind of ignoring that. It's almost like we're dealing with a vacuum. So I think the first thing that we can do is think a little bit more through the collection of efforts to try and implement something new, to think about that other side of the equation. The other thing, and I think folks within the VA have done this very nicely, is thought about ways to continue to expand the evidence base while considering implementation around the effectiveness of different interventions. And again, our evidence base for most interventions is incomplete, just given the heterogeneity of the population of systems, et cetera. And so the folks in the VA who have talked about hybrid studies around effectiveness and implementation can help as well, because it means that while we're focusing on implementation, we're continuing to gather that what is the impact at the individual level. And so I don't think we do either all that much. I think the other thing is just encouraging more people to focus exactly on de-implementation. There was a provocative question over the last few years that basically was trying to encourage more researchers to think of, you know, NCI studies around de-implementation, around, you know, abandoning things that don't seem to have value. We didn't get a lot, I would say, as much as we could, and so it certainly is an opportunity to continue to add the evidence base, but thanks for accentuating the point. Oh, yeah, David.
Barry, in response, I think de-implementation is a lot harder to do than implementation, and we need to think about the experience with prostate cancer screening, with aggressive breast cancer screening, where the wife of the Secretary of HHS concludes, I got screened, I got treated, I'm alive, therefore cause and effect. And it's much harder to take things away from people than to give them something. And I think that now we're in this market and sort of free-for-all, and everybody can have information about genetics. I think we risk not learning and using the lessons in the past, and it can be hard to de-implement, and we may need as a field to take a more aggressive stance about that.
I'll just posit that not only is it harder to do, but the strategies are not simply going in reverse, and the strategies are very different and understudied compared to implementation.
Yeah, good point.
One more. One of the challenges for genomics is the rapid changes in the science. I mean, since the EGAP recommendations in 2009, I mean, the field has moved very quickly. Now we're dealing with panels, we're dealing with whole, different markers, different sequences. So, part of appropriate implementation is to figure out what to implement and what not to implement. So we can't wait too long. I mean, even the guidelines will go stale after 5 years, even without genomics. And genomics is much more quickly moving and changing year to year than other areas.
Mark Jenkins, University of Melbourne. I just want to pick up on David's question. How do we know what the risk of cancer is in those mutation carriers who haven't got a family history? I'm trying to think of a design that you could enact to answer that question. And the only thing I can think of is you would have to sequence unaffected people in the population chosen at random, then wait 20 or 30 years, 40 years, until they did or did not get cancer. And given that 1 in 280 in the population are carrying a mutation, you'd have to maybe sequence hundreds of thousands of people and then wait 20 or 30 years. So essentially it's impossible to answer.
No, it's a big HMO, the UK.
Yeah, but they're going to have to wait many years for this to happen.
Yeah, you would.
The alternative is to ask the question, why would you think it would be different? In the absence of information, the null hypothesis would be that it would be no different. And we do this all the time in science. You could keep looking in case it's different, or you could just assume it's there, take the safe side, screen them if you find them.
Retrospective cohorts. Yeah. I mean, Larry Brody may have the answer for BRCA as well. I mean, people do that all the time. The difference in genetics is that people with family history share other genes and they share other factors. So it's a not unreasonable hypothesis that the penetrance should be higher in people with family history than somebody from the population. So it can be studied. And it can be studied retrospectively. I mean, if you get all these cohorts from the nurses studies and other cohorts that NCI and others have funded over time, I think we have a good idea of the natural history.
Just to disagree with Mark, I really do, but actually the Manchester people did some nice work where they looked at people who were BRCA tested who didn't have the mutation and they still had a higher incidence of breast cancer, arguing that the people that they were seeing in families, there were family-related factors that even after you took the BRCA out, they were still higher than the background population. So I think there will be some family-related factors that bring that family to attention.
So we know in Lynch syndrome, that once you identify the non-carriers in those families, their risk is the population risk.
Okay, so maybe simple.
I think that just to this last point, isn't that what the purpose of all of us is supposed to be, to enroll 1 million people in research and people who are, quote, very average so that we can assess the prevalence of these genetic predispositions in the general population. Whether or not we actually are able to achieve that, we'll see. All of you gave tremendous presentations and so thoughtful. I thank everybody for everything you've shared with us today. I've had the opportunity to interact with Juan and Muin previously. Joy, I think you hit the nail on the head with everything you talked about. And I think that goes back to what needs to be implemented beyond genetic testing. We talk about ethics. I think there's an ethical responsibility that if we're going to test people, we have to give them the means to get the follow-up care that they need. And that's something that our system here in the U.S. is not necessarily set up to do at the moment. We have, our insurers can pick or choose what they want to cover. One insurer will cover, you know, the colonoscopy for the 35-year-old because they say they're high risk. Another one will fight them. Same thing with BRCA mutation carriers. They're supposed to start getting breast MRIs according to NCCN. Some insurers are saying, well, you have to meet your deductible, so basically these women are paying $1,500 out of pocket every year to get these, you know, interventions. So, and this is a very challenging thing, and it's not something that a group of scientists can necessarily address, but I want it to be something that's on the radar as we move forward, that maybe our system needs to be tweaked somehow to make sure that when we do identify individuals who are high risk, whether it be through cascade screening or any other, you know, population-wide screening, that we have an ethical responsibility to help them get the follow-up care if we do, in fact, provide them with those genetic testing results.
Thanks.
Three things briefly. First of all, a little pitch from my little island across the water, John Byrne from Newcastle. The UK Biobank is, you know, we've got the 500,000 people there, so we're now at the point where we're getting genomic data from them, so we will get some genuinely, you know, sort of population-level information from that. The second point I want to make, which is we keep using the word screening, and I know the public health people in the room and the epidemiologists will get a bit anxious that it gets used rather loosely. And we need to be very careful to know when we're talking about truly screening populations and when we're simply talking about surveillance, or whether we're looking for mutations in a gene, and people often say we're screening the gene. So I think we need to use the word screening a little more carefully because it confuses the world. And the final point I want to make, just we were developing a course for our counselors on genomics, and I read a very interesting article in the BMJ where the writer constantly flipped across different peas in a pod, I call it. So there was the person, the patient, the public, and the politics. And sometimes these conversations pass in the night because you've got the genetic counselor worried about the person's life being wrecked by being given the VUS. You've got the doctor who feels like they want to do a test like they do all the other tests. The public health doctors are wondering how we deploy this into a population, and the head of NCI is wondering how you pay for it. And they sometimes are not synced together, and we just need to be clear in our minds when we're talking about patient or person, patient, public, or politics. I think that sometimes helps clarify the debate. Thanks.
So just to tackle the penetrance question again, because I think it's interesting, I'm going to agree with Mark. And the best analogy I think I've seen lately is we've been finding incidental E-cadherin mutations on panels, and that causes hereditary diffuse gastric cancer. But sometimes we're finding them from patients with no family history of gastric cancer. And then it's a bit of a panic because the intervention for these people is not trivial. It's removing their stomach. And are you going to take a stomach out of a person with an E-cadherin mutation who has no family history of stomach cancer or not? And the evidence that has been presented lately, Lena Stoffel's group at Michigan, would imply that, in fact, yes, they do have the same risk for gastric cancer as anybody else. And I guess my question is, what's a negative family history? Is it a small family where they don't know their family history? Is it a de novo mutation, and that's why there's no family history? Is it non-paternity, and that's why they don't know about their family history? So I think negative family history is not always negative family history, and I would tend to err on the side of Mark as of the default, assuming the penetrance. And I do know it is different. I mean, obviously the penetrance is different in our population-based cohort than in a high-risk clinic-based cohort, but I can't imagine it going down to 0 or to the general population risk.
I guess I just wanted to say something again, similar with the UK Biobank around the population screening. So at Geisinger, we have our MyCode Biobank where our patients are consented to also have sequencing and have results returned. So, and we have 100,000 so far. We've hit our target for the 100,000, we are pushing upwards. Our next goal is 250,000, and we are starting to see what are these population prevalences, how much do there for the BRCAs and the Lynch syndrome genes. What are we seeing in a general population sample compared to what we expect with the family histories? So we're hoping we will get some of that. Again, as you pointed out, though, it's going to take a very long time for us to see that in the general population of, is it any different with the cancer incidence, things like that. But there's lots of us working on that, or at least some of us are working on that.
Well, thanks.
I was going to address the impossibility, because too many things that are felt to be impossible are quite doable. And there are study designs to get at, and I think it's already been mentioned, retrospectively get a prospective assessment of risk of genes, and so we shouldn't declare that it's impossible at this point. But more to the point of the assumption, because it's a strong assumption that family history adds zero information to a so-called deterministic mutation in a gene. That's a pretty strong assumption because it assumes no modifiers. We already know that amongst families, the absolute risks differs. So I don't think it's a far leap. So this gets to the point, supposing we overshoot the mark. Whenever you are intervening with a preventive intervention, or I'll use the word screening loosely, screening the population, it's not a matter of whether the risk drops down to the absolute lowest. It's a matter, or to the average, is how far it drops, and because there are risks and benefits. And, of course, you're always measuring them, and you want to be sure if the risk drops below a certain level that you still are not maintaining the same level of harm, assuming that the risk hasn't dropped at all. So I think it's a worthwhile thing to know before we start preventing diseases surgically, because surgical prevention is not always an ideal preventive intervention.
Rick Boland, San Diego. One way to perhaps get around this issue of finding out how many trivial sequence variations there are that don't cause disease is to do a lot of sequencing on old people. I mean, take people who are 70 and 80, and if the mutations are there in that population, there's your answer.
Great. So one more here, and then we have a couple, I think, online.
But then the question is, why didn't they get cancer? So what are their modifiers as to what made them not get cancer? So a lot of what we've heard about this morning in terms of screening for cancer, I will try to be specific, for colorectal cancer has been colonoscopy, colonoscopy, colonoscopy. And obviously that is the gold standard. But in an effort to deal with this de-implementation up front, should we think of a screening trial in which to enroll all of these Lynch patients that we're going to find into a screening trial in which we're looking at different screening methods to reduce the risk of the cancer screening? As we've heard, colonoscopy creates harm. So thoughts on other screening methods for colorectal cancer in this population?
Anyone?
What you would want from a screening test in Lynch is for it to be very sensitive, so it was negative. You'd say the person doesn't have a lesion. If we look at the stool DNA combined with FIT test, part of the problem is that the DNA markers, they're methylated things that aren't strongly related to Lynch. Something else might be developed. And the FIT component does a lot of diagnosing, but Lynch things are off, they may not bleed. I don't know if it's been studied directly, but that's one of the potential problems. But some empirical testing could help. The problem is too, though, that if the risk is very high, you really want a test that's very sensitive so that if it's negative. So it's a reasonable question, but I don't know empirical studies. Rick, do you?
Yeah, actually, I think Exact at one time put mutated microsatellite sequences into their fecal DNA test. They were going to test it in Lynch syndrome, and they stopped doing it. And I have asked Gary Berger, I don't know how many times to assist, when are you going to resurrect it?
No, in the first generation it was there, but it had a small positive effect, and they took it out of the second. Yeah, but the thing that's available now is...
No, it's not in there now.
It was BAT26
but it's technically feasible.
Yeah.
And they could well design a study and say alternate with, let's say, you did colonoscopies every 2 or 3 years and do that on the other years and see if that would help some. It actually works, but they didn't see a big enough market in it.
Okay, so I think we have a couple things online.
We have one question for Joy concerning the assessing the demand for genetic counseling services into the future. If you've considered demand related to precision medicine, where incidental findings from tumor DNA suggest germline mutation and need for counseling and testing, that's something that you've thought about in those calculations?
So as we talked about, trying to project that kind of need is very difficult, because we can't, as a genetic counselor workforce, we can't only focus just on cancer itself. It's what other kinds of conditions might the public have that might require the utility of a genetic counselor for that conversation. So from our perspective, if people are doing the tumor testing, that should be a population that we're already working with, because we're already anticipated that if someone is being diagnosed with a cancer, that they have a potential to come in to see a genetic counselor. So when we do a population that one genetic counselor per 100,000 people, that can be healthy people and all other health conditions included in that. So that was part of the facet that was calculated in. So I would count the tumor testing as included.
So this is the second one, and I'm aiming this to Dr. Ransohoff from Travis Bray of the Hereditary Colon Cancer Foundation. It's a comment mostly, but you can comment on the comment. Thank you for your insights, quote, beyond cascade testing, unquote. Population screening for Lynch would be great from a colorectal cancer perspective, but we need to look beyond colon-based interventions. For example, interventions for women with Lynch syndrome are rather extreme, as they include hysterectomy and oophorectomy. So I think it would be great if we knew everyone who had Lynch syndrome, but we must not minimize the effects of population screening in a broader context. It would have to be concomitant with an increased knowledge of absolute cancer risk stratified by age and gene mutation, and an educated workforce of physicians capable of individualizing care plans for their patients. And whatever your comments are, I do think this relates to what Barry Kramer talked about before, which is balancing.
That's a very fair and important comment. I was focusing mainly on colon cancer, and the other cancers get harder because we don't have any strong imaging or treatment modalities that are easy, like colonoscopy, if we were to go in and try to take out polyps. So that is a very fair concern about possible downsides.
Can I ask Karen to make a comment about it? Do you have anything to add, since that's your area of expertise?
No, I mean, I think the comment has to do with the harm part of it. And so as we get into, I appreciated the comment about really having to study cascade testing, because we've been at it for decades, and we're not that successful. That's the brute force part of it. So kind of the attractiveness of more population testing at such a low cost, it's very attractive, but the likelihood of harm is huge. Increased cost, but really at the end of the day, patient harm. And so I had a conversation with Lainey today about, endometrial and ovarian screening. It's not very good. It's fairly burdensome. Even prophylactic surgery in someone who's had, a low anterior resection, radiation, it's not that easy to do kind of a hysterectomy. So all of those, I think, issues, again, for us to think in a multidisciplinary standpoint, it's more than just colon.
Okay, so let me say on behalf of those who deserve far more credit than I do, thank you very much for your attendance and all of the conversation today. We will be starting tomorrow at 8 a.m. sharp, so feel free to do whatever it is you need to do, and we'll look forward to seeing you back. So thanks very much.